Hey everybody, it's Dr. Wood, and today we're going to continue on talking about epi and biostats, and we're going to look at lecture 15 where we talk about common research designs using epidemiology. And fortunately, this will be a lot of review. We're just going to be talking about similar study types that we've talked about before, just kind of retooling them towards more epidemiologic sorts of investigations. Here are some of the objectives we'll hit on. You can check those out on your own. And so first off, we want to think about what the function of our research design is really going to tell us, right? So when we're performing research, we're trying to answer a question by using collected data, right? So we're asking ourselves, say, for instance, what is the frequency of disease in a certain place at a certain time, right? In order to answer that question, you want to have some descriptive information, taken from collected data. But it doesn't necessarily mean that obtaining that answer is always going to be a simple task, right? So a lot of times it depends on the type of study you're doing, what resources you have available to you, etc. And so what we're going to find is whether we're doing quantitative or qualitative research, all of it can be considered descriptive, at least at the bare minimum, right? And again, another big thing to point out is no research is better than the quality of data obtained. So you need to make sure that you're getting all of the information that you're looking for, make sure it's collected the same way every time. All that's going to help you to kind of increase the strength of your data, increase that internal validity, make it the best data possible. And so the rules that kind of govern the process of collecting and arranging the data are called our research designs, as we are familiar with. And so another reason why we might ask a question, or another question we might ask, is what caused this disease? And in this case here is where we start to develop hypotheses, right? We're talking about developing a list of possible candidates for a cause of disease, and then trying to do studies that really kind of help us to kind of sort of winnow away those different candidates, right? And so we tend to find that when we are kind of coming up with some of this data, especially from descriptive studies, we will generate one or more hypotheses, right? And that's why we start to do our hypothesis testing. Sometimes you can test multiple hypotheses with the same study. Sometimes you can only do one, depending on the design. And so making predictions from that hypothesis and then examining new data will then help us to determine if our predictions were even correct in the first place. And then once we have that information back, if we find out that our hypothesis is not supported and we cannot reject the null hypothesis, then we'll either discard it completely, modify it, and then perhaps test it again. So our specific research designs that are appropriate for hypothesis generation, and we'll find that others are going to be more appropriate for actual hypothesis testing. And so we'll find that some designs are better for one or the other, or they may be okay for both, depending on the situation there. And so we'll find that most of our basic epidemiologic research designs are designed to either sort of describe a problem or maybe a pattern of health issues accurately, and then also be able to show a sort of fair, unbiased comparison maybe between, say, a group with or without a risk factor, maybe a disease, or maybe if we had a certain preventative or therapeutic intervention, right? So you find there's types of descriptive studies we may look at, and then there's more experimental studies we'll get into. So what you're going to find is that when we're doing good epidemiologic research designs, we should be looking for sort of the following functions. So one, they may be able to sort of compare different variables together, right? So maybe we're looking at disease frequency, maybe between two or more groups at one point in time. Or maybe we want to look at one group, maybe before and after receiving a certain intervention, or maybe being exposed to a risk factor, right? Maybe we wanted to look at, see, the rates of carbon monoxide poisoning before and after a hurricane hit, right? That would be one way you can do things. You should be able to allow a comparison between, say, absolute terms. Say we want to look at risk differences or absolute risk differences, or we can look at it in relative terms as well, right? So if we want to look at a relative risk or an odds ratio, when you're starting to do your comparisons there, that's the typical sort of analyses you're going to be doing. And then it should allow your investigators to determine whether that risk factor in the disease occurred, and then based on that, whether or not we can determine a temporal sequence. We've already talked about certain study designs, say for instance like retrospective surveys and things like that don't really allow you to do so, but ideally that would be the case. And then obviously we would like to minimize biases, confounding, and other problems we talked about in the last lecture that may sort of complicate our ability to really interpret that data and take something away from it. So depending on the type of design chosen, they can help with the development of a hypothesis. They can help to test the hypothesis, or maybe do both in some cases there. Okay, we'll talk about how our different types here. So we'll look at how cross-sectional surveys can be used for helping to develop hypotheses. Then we'll look at cohort studies, and case control studies can actually be used both to develop and test hypotheses. And then how randomized controlled trials or field trials generally are going to be best for testing out a hypothesis to see how a new treatment or, say, preventative measure is going to be able to change, say, the rates of disease in a population. So this is a good, pretty big sort of chart here that will show you some of the advantages and disadvantages of the different study types that we're going to talk about. And again, you're probably familiar with a lot of these already. Some of these are the study types we've already looked at, but they are more specific to epidemiologic purposes. They may have a different name, but they're going to be pretty similar to what we've already seen. So we'll get into these in more detail. So let's look at our observational designs for our generating hypotheses. So the first thing we want to talk about is going to be our cross-sectional surveys here. And so this is basically looking at a population at just a single point in time. And so as an example here, maybe we do like a survey. Maybe we have trained interviewers that are maybe either going to people's homes, or they're calling people, or they are mailing out questionnaires and things like that. Tend to find these are quick and easy, but the big problem is going to be responsiveness. You tend to find that a response rate tends to be fairly low in a lot of cases there. One exception we've seen before in our journal clubs is actually the U.S. Census, where people are required to by law and to respond, and they'll actually have people follow up with them if they're a non-responder, which is pretty standard. So again, depending on the data you're working with, maybe responsiveness is not a problem. Now, as I mentioned, cross-sectional studies are really good for quick and dirty sort of studies here. And again, maybe you just want to look at the prevalence of a risk factor. Maybe you just want to look for, say, for instance, looking at the current prevalence of certain disease states, things like that. This is also helpful for looking at the health status and maybe planning for some types of health services, right? So maybe if they wanted to, say, a state government wanted to work on priorities for the health department, they're looking at prevalence of certain diseases. That can actually help to set that, to say, well, wow, we have a lot of cases of, say, hepatitis. Maybe we should start to focus on that for the year. And a sort of cross-sectional observational study can do that. A big disadvantage, though, is that the data that we're collecting, especially in terms of more information about the exposure to risk factors and then the presence or absence of disease, are collected at the same time. So temporal relationships are generally very difficult to determine. And even then, if we could get more information about that, sometimes you'll find that things like recall bias and whatnot can make that, again, very difficult to determine. And so another case why this is not great is because it does really try to have kind of selects out for more long-lasting, more indolent cases of disease. If it's something that occurs very quick and is gone very quickly, say for instance influenza, it may be harder to catch when you do that single point in time. And so things that are more likely to be found are things that people live with for a long time, like hypertension, diabetes, things like that. And then especially severe cases that tend to be fatal are also not found as easy because most of these patients have already died. And that's what they call a Niemann or a late look bias. Okay. And then another case here is what we call a length bias in screening programs, where we tend to find, say, less aggressive cases because they live longer and then are more likely to be available to be found at that screening there. So again, patients who have less severe disease or diseases that last a long time tend to be more easily found by cross-sectional surveys. Things that tend to be more deadly, more severe, things that are fairly short-lived tend to be more difficult to find with a cross-sectional survey. You can find that repeated cross-sections may be useful for looking at changes, especially like changes in risk factors or disease frequency over time. But again, it does not give you more information about any kind of cause in terms of their association. But what we can do is by looking at the surveys, we can look for these associations and then generate hypotheses, and then move forward with a different type of study design. These are not going to be good for testing the effectiveness of interventions or for testing a given hypothesis. Next up, we have a cross-sectional ecologic study, and this is going to be a little bit more specific to where we're looking at relating frequency of some sort of characteristic with an outcome of interest. So kind of getting a little bit more specific, and generally they're going to relate that back to a specific geographic area. So say, for instance, we're looking at smoking and the outcome of lung cancer, and we wanted to say, look at the state of Florida, right? Again, these are good for looking for hypotheses, for generating them, but they're not good for developing a causal relationship, right? Oftentimes they can't rule out a lot of other causes that could be playing a role here. They just really cannot do that. It's not really what they're designed for. And so again, they can look for these correlations. They can look for associations. But the problem is that, say for instance, a study's done, a cross-sectional ecologic study is done. They say, look at this. If you eat this much chocolate, you have this rate of death. And then oftentimes patients who hear these news stories and things like that, they're not aware of the statistical issues with the study. And then they say, okay, well, obviously this is going to be a big problem. We got to do something about this. This conclusion may or may not be correct. In a lot of cases, people don't actually realize that. You'll find that there are cases in which important hypotheses initially suggested by a cross-sectional study are then later proved correct. So for instance, looking at rate of dental caries in children was found to be a lot higher in areas with low levels of natural fluoridation in the water than areas with high levels of natural fluoridation. So again, they found that there was an association there, but then they did subsequent research that actually bore that relationship out and found that, okay, by treating our water with fluoride, you can actually decrease the rate of dental caries. Next is a longitudinal ecological study. And longitudinal basically means we're using ongoing surveillance, or maybe doing pretty frequent cross-sectional studies in order to measure trends, right? So instead of just looking at a single point in time, we're kind of looking at serial points in time to get an idea for how things are changing. So maybe we want to look at disease rates and how they change based on the effects of certain big cultural issues like wars or immigration, things like that. Say, for instance, you want to look at the introduction of a certain type of vaccine and then seeing how the rate of the disease is in the U.S. population afterwards, right? And so using a longitudinal study can really help to look for those trends. Again, good for associations, not good for causation. You may find that confounding can be a big problem with these studies. It may distort the conclusions there. And so investigators should then perform field studies afterwards if they want to look at the effects of a large-scale public health intervention. We'll talk about field studies a little bit later on. But again, looking at things like research the rates of malaria in the U.S. population since 1930, and they'll find that peaks in malaria rates tend to be related to certain events. So maybe there's certain cases where there's a large amount of immigration, tend to see a spike, and that's where longitudinal ecologic studies can be useful. Again, here showing this case of malaria, you saw that as time goes on, you see little spikes. Say, for instance, people coming back from Korean War spikes up, returning Vietnam War veterans, etc. You can see how these sort of social changes cause spikes in disease to occur, and that's where longitudinal studies can help us with that. So next up, let's look at some types of study designs that can help us to both generate and test hypotheses. And so a lot of these will start off with using sort of a longitudinal ecological study. So for instance, if they were looking at rates of smoking and lung cancer in different parts of the population, again, they can't really detect causal relationships between here, but this is why they do follow-up studies where maybe we can start to look for those relationships, and that can be done either through cohort or case control studies. Now, the nice thing here, we're already pretty familiar with cohort studies. Remember, this is where people are being lumped into categories based on their exposure to a risk factor, right? Or a particular type of exposure. Typically, you're working with random samples of a population and saying, okay, well, here are the smokers in this one group, here are the non-smokers in another group. Otherwise, they should be similar to one another in terms of, say, age and sex, based on socioeconomic status. All those things should be similar. The only difference really should be the fact that some are smokers and then some are not. And then you can look forward to see, okay, well, is there an actual causal relationship here in terms of the amount of lung cancer is actually happening? Remember that the defining part here, again, is the basis of exposure. So were they exposed or were they not? This is going to be different to our case control studies. As we remember, case control studies are where we are working with patients who have the disease versus those that don't. And then we're looking back in time to see what were the odds of them having a certain risk factor or not, right? And again, there's two main types of cohort studies, prospective and retrospective. Again, looking at the present time and then seeing where your data is going, it will help you determine if it's prospective or retrospective, as we know. Looking in the case here, we have a prospective study. Again, this is going to be more labor intensive to do, but you're starting at the present time, grouping people based on risk factors and then following to see what the outcomes were. Retrospective cohort studies where you're going to be starting in the past and then lumping people together based on the risk factors and then moving forward to the present time to see what the outcomes look like. Again, my research on coral snake envenomations was a retrospective cohort study. And then finally, the case controls where you're starting with the disease on the outcome and then looking backwards to see the presence of risk factors in those individual groups. Now remember, the benefits of a prospective cohort study is that we can typically draw better or stronger cause and effect relationships here, because the investigator is basically able to control and kind of standardize the data collection as the study progresses. A problem with retrospective cohort studies is that you're kind of at the mercy of what data is available to you, and if you have bad data, then that's kind of all you have to work with, versus something that's prospective. The researchers have a little bit more sort of leeway with that, and they can help to standardize the process a little bit more. You're going to find that when you're looking at these prospective cohort studies, you're looking at risk, right? You're looking at the risk of the outcome occurring. You're looking at incidence of outcome occurring in the groups based on their risk factors here, right? And a lot of different types of diseases can be studied this way. The disadvantages of a cohort study is, again, you're only looking at the risk factors as defined and being measured at the beginning of the study. So you can't just change partway through and decide to include more risk factors, because now your data is not going to be consistent, right? Also, it's going to be more costly. You may have people that are lost to follow-up, and there tends to be a long wait time because you have to wait for the study to actually run out. Again, the most kind of famous cohort study we have is the Framingham Heart Study, which was started back in the 50s and continues even on today. Retrospective cohort studies, as I mentioned, is basically starting in the past. You're still lumping people based on their exposure to a certain risk factor, whether coral snake bitten patients, whether they got early antivenom or late antivenom. That's what we look for. And then you go forward looking in time to see, okay, well, who had the outcomes we were interested in? And you're still going to be calculating risk there, right? Because you're actually going to be looking at the incidence of the outcomes as time went forward in those cases there. And again, much easier to do, much cheaper, because you're already working with data that's already been collected. On the flip side, if you're doing a case control study, we know this is where we're lumping people based on whether they've had the outcome or not, and then looking backwards in time to determine, do they have the risk factors present or not? And that's where we're working with our odds ratios. Remember, the odds of having the risk factor versus the odds of not having the risk factor, and then comparing the cases versus the controls there. What's interesting is that the case control studies are actually very similar to the cross-sectional studies. The one difference is, actually the similarity there is because you're actually getting information about both the risk factors and the diseases at the same time. The big difference though here is with case controls that I'm actually breaking down the groups into those that have the disease versus those that don't, and that's how I'm able to do my comparisons. I'm then able to look at their risk factors and see, okay, what are the odds of people with lung cancer being smokers rather than the odds of those who did not have lung cancer not being smokers, right? You can look at those two together and come up with those odds ratios. A benefit of a case control study is that it is especially useful for when the disease state, the prevalence is very low, because basically once you collect those few people, then you control them with several control cases and then look back to see their risk factors. If it's a really rarely occurring disease, say 1 in a million, you have to have a lot of people in a cohort study to even show anything. And so that's why you either have to follow for a long period of time or a lot of people to really show something. Case control studies are only looking at one outcome and one disease, but they may be able to look at a lot of different risk factors, right? Again, case control studies are good for generating hypotheses. Maybe it'll show some causes of a disease, but they're really better for kind of generating hypotheses. Cohorts are a little bit better at being able to test hypotheses. The disadvantages of the case controls, as we kind of alluded to, is that determining the risk factors to look for can be an issue of potential recall bias. Patients may not remember, or they may remember much more intensely if they have the disease in question. And then it's not easy to know what the correct control group is going to be. You have to make sure you don't over-control for the group, but you don't have them be completely different. So it's a matter of finding that kind of Goldilocks right there in the middle sort of kind of patients to use as your controls there. Typically, those going to be based on age, sex, and often race to match for those possible things there. They maybe get more granular depending on what they're looking for, but that's typical. As I mentioned, overmatching is a problem where the controls look so much like the cases that it's very difficult to determine a difference in the risk factors. And so because of that, it would be very more likely to make a type 2 error because the two groups look so similar to one another. And so in this case here, if you're looking at causes for lung cancer and you had the cases and controls had both been matched on the smoking status, then that wouldn't have been able to be used to look as a causal factor because, again, they would already be matched based off of that. Now let's switch gears a little bit and talk about designs for testing hypotheses. And so this is going to come down into our randomized controlled clinical trials, which we're very familiar with. And then slightly different is going to be our randomized controlled field trials. And basically the steps to produce these are pretty much going to be the same, and they'll have the same advantages and disadvantages. The main difference between the two is that typically clinical trials are looking to test some sort of therapeutic intervention in patients, say, for instance, with a disease state. If field trials are usually done for more preventative interventions, say, in well persons in the community. Say, for instance, you were to initiate a new campaign against childhood obesity, and you're looking to see what the rates of weight loss in kids were, or something like that. That would be considered to be a field trial where you're actually looking for preventative sort of intervention in people who may be well, right? And so again, you can be recruiting a random sample of people. You then randomize them to either have their experimental group or be put into the experimental group versus placebo. Again, you're measuring everything at baseline to make sure they're very similar between the two here, to make sure that there's no big differences. If there are, that can introduce bias. And then you measure them for the outcomes. The processes are going to be the same, whether it's a controlled trial or a clinical trial versus a field trial. Now, the big benefits to a randomized controlled trial is it's kind of the gold standard for studying cause and effect sort of analyses here. However, because patients are randomized, it helps to eliminate a lot of bias and minimizes it, but it does not get rid of it entirely. But again, doing these kind of studies can pose challenges, right? And ethical dilemmas and things like that. Do I use my control group as receiving no medication for a given disease state, or do I need to have some sort of gold standard, some sort of standard of care intervention? That can be difficult, and that's why we have groups that are available to kind of help with the ethical aspects of these. And again, to be enrolled in a randomized controlled trial, patients have to be willing, right? They have to be able to participate and give consent for these. And again, helpful things to help eliminate bias includes like blinding. We've talked about what helps with that, whether it's single-blinded or double-blinded. And again, frequently the treatment that you're using has to look exactly the same, such that researchers and the patients don't really know the difference there. For that physician's health study we talked about last lecture, so here's the pill packets. And so they'd alternate between taking the tablet and the capsule, and these looked identical between those that were receiving active drug and those who were getting placebo. Again, the point there is so that the patients have no idea what they're receiving, and there is some means, usually a code or something like that, that will be able to tell researchers, whoever is unblinded, which one the patients are actually getting. And so it's generally impossible to have patients participate blindly in, say, a surgical intervention, because that would require them to undergo a sham operation. But sometimes it happens, right? So, for instance, certain studies we do sham LPs, we do lumbar puncture, so patients may not know the difference there. So all of it goes back to making sure you have the proper clearances from the institutional review boards to make sure there's no issues in terms of the ethics of a study. When looking at randomized controlled trials, it's also important to look at the reasons why patients may be lost to follow-up. So, for instance, if you're doing a study with advanced cancer, maybe the patient fails to respond and they decide to go with a different treatment, or maybe they die. Other cases there, maybe the patients undergo side effects and they just don't want to participate in the study anymore. And again, that's their prerogative. They are allowed to remove themselves from a study at any time. To bar them from doing so would be a huge ethics violation. So, like I said, if a patient were to participate in a study for antihypertensives and they develop erectile dysfunction, they don't want that to happen, they can stop the study at any time. But it's important for the researchers to investigate why they were having dropouts and to account for that. Also, a lot of publication bias, as we've mentioned, and again, people don't like to publish negative results, and that may make it very difficult because the negative results are just as important as positive results. And so a lot of studies go unpublished because the data doesn't really show much and they're not really that exciting, but they're still important. And then it's always important to look at pharmaceutical companies to see who is really investigating the data here, right? So if a pharmaceutical company has been paying for a clinical trial and it doesn't show anything, they may not be very likely to publish that results there, right? They want their drugs to look good. And so again, publication bias is a huge issue. It's always something to consider when you're actually looking at a set of data to wonder, okay, well, what were the negative results? This drug looks awesome. It looks like it's going to be great. But what were the negative results that were not maybe published? So as I mentioned, field trials are very similar to clinical trials, except they're usually going to be for some sort of preventative measure. And so you'll find that it's still appropriate to randomly allocate patients to whether they receive the preventative measure or the placebo. And then you follow them to look for the rate of disease in each group. So very similar to a clinical trial in that respect. Some examples might be to look at, say, vaccines to prevent polio. Maybe initiating a 6-month course of isoniazid for patients who had a positive tuberculin skin test to see if they convert over to have active TB, or maybe aspirin to reduce cardiovascular disease. You're going to find that with a lot of these, the advantages or the disadvantages is that you have to follow them for a long period of time. You can't just say, okay, we did this for 6 months and we saw that you didn't develop TB, so you're good to go. It may take a lot longer than that before you really find those results. So as an example, the Physicians' Health study illustrates the problem where the aspirin arm began in 1982 and they did not get results for 7 years. It's a long time to run a study. Imagine most of you probably have not done anything in your life other than maybe, primary school for more than 7 years. So again, it's a very long time to be committed to doing one study. Other disadvantages have to do with their external validity. So as I mentioned in the last lecture, the ability to generalize is very important. And when you're looking at a study, it's really important that you're considering how this applies to your patient, because you're probably reading it for a specific case, a specific use case, and you have to find out, is that generalizable to your patient? Does it make sense? And if not, then it may not be that useful of a study to you, right? And so they need to be really clear about what sort of population they're looking at to see, is it generalizable? So anyways, that's going to be it for this section. If you have any questions, please let me know, and I'll talk to you soon. Thanks a lot. Bye.